Hello, a very good afternoon from Singapore. Welcome to the 26th International Society of Cardiovascular Pharmacotherapy meeting. And our theme for the meeting this year is keeping in beat with advances in cardiovascular pharmacotherapy. So welcome to the first session of the Sunday today, and it's on precision medicine in the use of antithrombotics, fact or fiction. I'm Doreen, and I'm a pharmacist. I am currently with the National University of Singapore Department of Pharmacy, and I'm very glad to have with me a whole panel of different people from different parts of the world to share with you the expertise and experience with precision medicine in their various capacities. We have got Prof. Andrea Jorgensen and Dr. Pereira, who are able to be sharing with you about their experiences, as well as Mr. Kim, who is from Singapore. So the first speaker that I'm going to be introducing is Prof. Jorgensen. Before I go into introducing the first speaker, let me just share with you some disclosure. The content of this webinar is copyrighted by the ISCP and should not be distributed without the prior permission of the ISCP. The views and opinions expressed by the webinar are those of the faculty members and do not necessarily represent those of the ISCP. The sessions will be live streamed via Wonder and ISCP and APSC Facebook and YouTube pages. The European Board for Accreditation for Cardiology, or EBAC, will grant the CME points for attendees who attend the full sessions. You will be receiving your certificate of attendance upon completing a survey, which will be sent via email after the seminar. So if you have questions along the way, please feel free to be typing in your questions in the live Q&A box on the website on the right. And these questions will be discussed at the end, where we'll be having a panel as well as a Q&A session. Now, if we don't get to answer all your questions, do not worry. You'll be able to email questions to the Secretariat at the email address listed here below. So let's just introduce Professor Andrea Jorgensen. And Professor Jorgensen is a professor of biostatistics from the University of Liverpool in the United Kingdom. She's got a lot of experience to do with DOACs as well as warfarin genotyping. And she'll be sharing with you about the use of warfarin genotyping in the advent of use of direct oral anticoagulants. How do we really want to be thinking about warfarin and similar vitamin K antagonists today? Now, a lot of the use of the VKAs have been dwindled, and this is mostly due to the numerous times that we need to measure the INR and associated dose adjustments. It's troublesome and is deemed to interact with a lot of drugs and food, which would occur very commonly when we use the VKAs. Now, as the experience with the DOACs grow, there's so much overwhelming safety data compared to the VKAs, and there's little standing in the way of using DOACs for almost everything in a day-to-day practice. So in this session, Prof. Jorgensen will be covering the clinical scenarios where warfarin genotyping will be clinically relevant and how warfarin genotyping can be implemented in the day-to-day practice. Let us welcome Prof. Jorgensen.
Hello, and thank you to the organisers for inviting me to give this talk today, where I'll be looking at why a genotype-guided approach to anticoagulation might be a really good option. My name's Professor Andrea Jorgensen. I'm a Professor of Biostatistics in the Department of Health Data Science at University of Liverpool, UK. So, evidence from randomised controlled trials and meta-analyses show that DOACs are equivalent, if not better, than warfarin for efficacy. And there is some evidence also to suggest that DOACs offer a reduced bleeding risk. However, there's also evidence showing that there's an increased risk of GI bleeds with DOACs as compared to warfarin. This evidence base has led to a significant shift in clinical practice in the UK, where a large increase in prescribing DOACs has been seen. So why are we still so interested in warfarin? This is partly to do with cost. And it's been estimated that the average monthly cost of warfarin is about 83 pence a month, whereas the cost associated with DOAC treatment is over £50 a month. And in England, the National Health Service saw cost of anticoagulation increase by over £100 million in 2015-16, and about £400 million in 2016-17. And this trend is set to continue given our increasingly elderly population, therefore an increasing need for anticoagulation. We must acknowledge that some DOACs will come off patent in 2022, but these substantial costs are worthy of considering alternative to the usual one-size-fits-all approach to anticoagulation. It's important to note as well that these costs do not consider the cost of treating adverse drug reactions associated with anticoagulation treatment, but of course the aim is to avoid these or reduce the risk of these adverse drug reactions by using the most appropriate anticoagulation drug for a patient, and we'll consider this later. Patient behaviour also plays a part. Warfarin and DOACs have quite a different regime in terms of dosing, and this can potentially cause a difference in the rate of adherence to those anticoagulants. So for DOACs, there are no routine monitoring requirements, and this can lead to the opposite of white coat compliance. So the fact that a doctor is not checking you're taking your drug might make you less likely to take it. And also for some DOACs, the dosing is required twice daily, and this can also lead to a reduction in adherence. In fact, a study in 2017, which looked at the adherence based on issuing of repeat prescriptions, found that adherence on DOACs reduced to approximately 34% adherence, whereas adherence for warfarin was maintained at about 74%. And of course, randomized controlled trials that compare warfarin to DOACs don't capture this difference or variability in adherence due to the artificial setting and highly monitored setting within a randomized controlled trial. So here we have a plot from the study I mentioned that shows a great reduction in adherence for some of the DOACs, whilst the reduction in warfarin adherence is much less and stabilizes at around 74% here. Age is also an important factor on the efficacy of different anticoagulants. And we know that all DOACs to some extent have a degree of renal excretion. And therefore, poor renal function can cause DOAC sensitivity. And this is a bigger concern in the frail elderly population, where renal function can reduce due to other illnesses. Drug-drug interactions with DOACs are also often not given enough consideration. And again, this is a particular concern for the elderly due to the issue of polypharmacy. There are guidelines to suggest regular renal function testing with DOACs, but these guidelines are not always followed in practice. And in addition to this, laboratory tests are lacking for regular anticoagulation control monitoring for DOACs, which makes this a large problem, particularly when we consider the impact of renal function on DOACs. So whereas with warfarin we have very well validated tests for monitoring INR control, this is not the case for DOACs themselves. So whilst randomized controlled trials show superior efficacy of DOACs, it's also important to consider how a shift in anticoagulation from warfarin to DOACs in clinical practice impacts patient outcomes in reality. So Alfirovich et al. In 2020 did exactly this by collating data from over 5,000 GP practices in England for the period 2011 to 2016. And they focused in particular on the annual number of DOAC items prescribed as a percentage of total anticoagulant items prescribed, and also on the outcome of adverse events, which is the rate of emergency admissions for bleeding or thromboembolism in each GP practice. And their findings were very interesting, showing that for each extra 10% of DOAC prescriptions, there was an almost 1% increase in emergency admissions due to bleeds. There's been a lot of attention over the last few years on improving anticoagulation control on warfarin by studying the pharmacogenetic factors, so the genetic factors influencing warfarin dose requirements. And many dosing algorithms have been proposed based on genetic data, clinical and demographic factors, so looking at genetic, clinical and demographic factors in combination and using those to predict dose. And trials of pharmacogenetic guided dosing have shown an improvement in anticoagulation control as compared to standard approaches in practice. One of these trials is the UPAC trial, and here's an extract from the UPAC trial publication where it was found that there was an improvement in time and therapeutic range for those where dose was predicted using a genotype guided algorithm as compared to standard practice in terms of warfarin dosing. Another trial was the GIFT trial that found a statistically significant difference in the number of adverse events experienced in the two trial arms, where the genotype guided arm experienced a lower occurrence of adverse events. In terms of these pharmacogenetic algorithms, the key genes influencing warfarin dose requirements are CYP2C9 and VICOR-C1. And patients with variants in these genes are said to be warfarin sensitive. Therefore, they require less dose and are at an increased risk of experiencing adverse events at more typical therapeutic doses. An interesting finding of a trial of edaxaban versus warfarin was that edaxaban led to a reduced bleeding only in patients with these sensitive genotypes. So they found that the reduction in bleeding on edaxaban was a lot more significant in those with sensitive genotypes. So based on these findings, a stratified approach to anticoagulation treatment may have many benefits. So the idea here would be to genotype patients before they start anticoagulation, and those without the sensitive variants for CYP2C9 and VICOR-C1 would be prescribed warfarin, and those with the sensitive genotypes would be prescribed DOACs. And this would obviously save huge costs whilst maintaining the same efficacy. And using pharmacogenetic dosing algorithms in those not best suited for DOACs would also maximise the benefit-risk ratio of warfarin for those patients. This would mean, for example, using pharmacogenetic guided dosing in the elderly population, particularly those with renal impairments or those on polypharmacy. This would mean them getting a more appropriate dose, as well as being able to be monitored regularly with dose tailored as appropriate. And this is entirely feasible for warfarin, as I said previously, where we've got many validated tests for anticoagulation control based on INR. And some of these tests can also be conducted at home to save the patient having to come into clinic for each INR test. So let's consider how feasible such suggestions would be in practice. So we conducted a study comparing clinics where genotype guided dosing was implemented to match clinics which were using a standard approach to warfarin dosing. And what we found in this implementation study, not only was there improved anticoagulation control in the clinics where genotype guided dosing was used, but also both patients and staff using the genotype guided approach viewed it as a very positive experience, showing that implementation is feasible in clinical practice. And there were only some minor adjustments suggested to allow smooth implementation of a genotype guided approach to warfarin treatment. And to end this presentation, a very important note about anticoagulation in developing countries, such as the African nations. In developing countries such as Africa, access to medicines is limited, and warfarin therefore remains the anticoagulation of choice. However, the current dosing regimes for warfarin are empirical, and that together with a lack of infrastructure leads to poor anticoagulation control. In addition to this, countries such as those with sub-Saharan African population are under studies in terms of pharmacogenetics of warfarin. And therefore, here at Liverpool, in collaboration with collaborators in Uganda and South Africa, we are undertaking a large programme of work under the project name Warpath, with the aims to improve anticoagulation control by developing dosing models, including both clinical and genetic factors that are relevant to the sub-Saharan African population. And this will hopefully improve anticoagulation control in these countries where warfarin is the obvious choice of anticoagulation. So to summarise, there has been a large shift in prescribing from warfarin to DOACs in the UK based on the current evidence base. However, as we saw, DOACs are not always better, not only because of cost, with warfarin being so much cheaper, but also because of issues such as patient adherence being poorer on DOACs, and also some patients, particularly the elderly, not always suited to DOACs. And we also saw how important a role pharmacogenetics can play. We then went on to suggest a stratified prescribing approach where all patients were genotyped to identify those best suited for warfarin and those best suited for DOACs. And we also discussed a genotype guided approach to warfarin treatment, particularly in the elderly, and in particular for that population where they can be monitored regularly, which is the case for warfarin treatment. And finally, we discussed how important it is to continue research into improving anticoagulation control in developing countries such as sub-Saharan Africa, where warfarin remains the anticoagulation of choice.
Thank you, Professor Jorgensen. And that was Professor Jorgensen telling us about what she thought was the role of warfarin genotyping. Let's welcome our next speaker, and he's none other than the PI of Taylor PCI, Dr. Naveen Pereira himself. He's the Professor of Medicine at the Mayo Clinic College of Medicine. He'll be addressing us on CYP2C19 guided P2Y12 inhibitor or universal Ticagrelor. Just to tell you a little bit more about his talk today. While popular genetics demonstrated that genotype-guided de-escalation of P2Y12 inhibitors was non-inferior to standard dual antiplatelet therapy with prasugrel or ticagrelor, Taylor PCI seemed to have received a lot more attention when the primary endpoint of major adverse cardiovascular events, or MACE, was not statistically different for genotype-guided selection of P2Y12 inhibitor therapy compared to the conventional DAPT with clopidogrel. So also, we know that the current American College of Cardiology and European Society of Cardiology guidelines have not strongly advocated the use of genotyping in the selection of P2Y12 inhibitors. So the cardiology community mostly feel there's no need to explore genotyping since ticagrelor is going to be a default choice for DAPT following PCI. So in this segment, Dr. Naveen Pereira will address the issue of why Taylor PCI findings should still be taken into clinical consideration. And he will use recent evidence from meta-analysis to recommend the clinical positioning of CYP2C19 testing in decision algorithm in day-to-day practice. He will also address the issue of concern with differences in ethnicity, and particularly the people with lower MACE risk and maybe a higher bleeding risk, maybe in Asians. Dr. Pereira, please.
Hello, my name is Naveen Pereira. I'm Professor of Medicine at Mayo Clinic, Rochester. It's my pleasure today to speak at the meetings conducted by the International Society for Cardiovascular Pharmacotherapy. My task today is to convince you that the right approach in clinical practice is to use CYP2C19 guided P2Y12 inhibitors rather than prescribe ticagrelor or prasugrel for all. So we know that clopidogrel is a prodrug, and it requires the cytochrome P450 enzyme CYP2C19 to convert it to an active metabolite. We also know that there are patients who are CYP2C19 loss of function carriers who are unable to convert the prodrug to an active metabolite and hence are resistant to the action of clopidogrel. These individuals are highly prevalent. There may be 1 in 3 individuals who may have loss of function carrier status. We know that carriers, as compared to non-carriers, have markedly reduced active metabolite levels when you measure these in the blood. And we also know that CYP2C19 loss of function carriers have greater platelet aggregation or less inhibition of platelet aggregation when treated with clopidogrel as compared to non-carriers. It's been well established by multiple observational studies, and this is encapsulated in this meta-analysis that has shown that there's a 57% increased risk of cardiovascular death, myocardial infarction, or stroke in carriers as compared to non-carriers when treated with clopidogrel. So why haven't we identified the loss of function carriers and use CYP2C19 genetic testing to guide P2Y12 inhibitor therapy? And a major reason we haven't done that is the Plato genetics sub-study. And the conclusion of this genetic sub-study is Ticagrelor is a more efficacious treatment for acute coronary syndromes than is clopidogrel. And it is more efficacious irrespective of CYP2C19 genotype. And the use of Ticagrelor for all instead of clopidogrel would eliminate the need for genetic testing. But if we closely evaluate the data presented in that genetic sub-study, we find that in loss of function patients, the event rate when treated with clopidogrel was 11.2%, was reduced to 8.6% or 33% risk reduction with Ticagrelor as compared to clopidogrel. But the not loss of function patients, the risk reduction was 14% and the p-value was not significant. But the authors did what is known as the p-value for interaction to see whether this genetic status or genotype made a difference in driving these risk reductions or whether it was the effect of the drug alone. And the p-value for interaction, the study was not significant. Hence the conclusion that it didn't matter. Ticagrelor was efficacious over clopidogrel. However, it is very important to recognize that when you look at p-values for interaction, you need to have adequate power. And the sub-study, the authors acknowledged, was not prospectively powered and had to be based on the number of blood samples available for genetic analysis. We demonstrated this in a prospective way that patients who are loss of function and who get assigned to clopidogrel in the conventional therapy arm in Taylor PCI had a higher event rate when, as compared to those who are receiving Ticagrelor. The risk reduction was 34%. The p-value was statistically not significant because we powered our trial to show a 50% risk reduction, and we found a 34% risk reduction. But when we examined the critical first 90 days after PCI, we found an 80% risk reduction of post-hoc analysis, which are highly statistically significant, with genetic guidance in loss of function patients as compared to conventional therapy with clopidogrel. And furthermore, when we looked at all events that occurred per patient prospectively, we find that genetic guided therapy resulted in a 40% risk reduction with a statistically significant p-value as compared to conventional therapy. Now, the trial that really examined whether genetic guided therapy is non-inferior to giving Ticagrelor for all in the standard treatment group was Popular Genetics. And what they found that this genetic guided strategy was non-inferior compared to giving Ticagrelor for all when it came to reducing events like death, myocardial infarction, stroke, stem thrombosis, or major bleeding. Now, when you examine just the ischemic outcomes, again, there was no significant difference between genetic guided therapy versus standard care giving Ticagrelor for all. However, the bleeding outcomes were greater in giving patients Ticagrelor for all as compared to using genetic guidance. We then performed a meta-analysis, given that we understood Taylor may have been underpowered. The Lancet paper that published the Plato genetics sub-study may be underpowered. So we took all the clinical trials that compared Ticagrelor or Prasugrel with Clopidogrel in loss of function patients and in non-carriers. And we find that in the loss of function patients, when we prescribe Ticagrelor or Prasugrel, you get a 30% risk reduction. So it does make a difference in loss of function patients. But importantly, in non-carriers, there is no difference whether you treat them with Prasugrel or Ticagrelor as compared to Clopidogrel. And importantly now, we were adequately powered to evaluate the test of interaction based on CYP2C19 genotype. And this was now statistically significant with the 16,000 plus patients that we examined in this meta-analysis. What this means is, yes, the effect of Ticagrelor or Prasugrel as compared to Clopidogrel is primarily driven by the presence of CYP2C19 genotype. And therefore, we come up with this treatment algorithm. The patients with coronary artery disease, who have acute coronary syndromes or PCI, who undergo genetic testing, we are then able to identify the loss of function non-carriers, which are the majority of the patients, 70%. And if you treat them with Clopidogrel or Ticagrelor Prasugrel, it makes no difference. But if you identify the smaller proportion of patients who are loss of function carriers, and you treat them with Ticagrelor Prasugrel as compared to Clopidogrel, there's a 30% risk reduction. So genetic testing allows you to implement precision medicine by identifying the Clopidogrel resistant patients and giving them alternative therapy, while the patients who are non-carriers, in whom Clopidogrel should work just fine, you can give them Clopidogrel. A more recently published meta-analysis in Lancet supports this concept of precision medicine, that a precision medicine approach as compared to giving Ticagrelor or Prasugrel for all results in a reduction in cardiovascular death, myocardial infarction, stent thrombosis, stroke, and minor bleeding. It's also important to recognize that giving Ticagrelor or Prasugrel for all is more expensive than giving Clopidogrel, a drug that's been available for decades. The cost of genetic testing has come down significantly. It is less than $300 right now in the United States if we use the Spartan genotype assay that we used in Taylor PCI. In summary, the advantages of using genetic guided P2Y12 inhibitor therapy are you'll have less bleeding because Ticagrelor or Prasugrel cause more bleeding, and with genetic guidance, you're giving less patients Ticagrelor or Prasugrel. You'll have similar ischemic outcomes, similar efficacy, giving most patients Clopidogrel, but only the loss of function patients Ticagrelor or Prasugrel. And you will avoid side effects like dyspnea. You'll avoid the contraindications for Prasugrel, like the very elderly, low body weight, prior CVA, and improve compliance by giving Clopidogrel once daily rather than Ticagrelor twice daily. So thank you very much for your attention. I'd like to acknowledge all my colleagues and the multitude of principal investigators that made Taylor PCI possible. And I welcome any questions or comments after this presentation. Thank you for the opportunity, and I look forward to interacting with you. Thank you. Bye.
Many thanks, Dr. Pereira, for sharing with us on your perspective with respect to whether we should be genotype-guided choices of P2Y12 inhibitor or to use universal ticagrelor. Next up, we have a local talent, Mr. Kim Ji Heon, and he's a senior clinical pharmacist from the Khoo Teck Puat Hospital. He's going to share with you his work on cost effectiveness of genotyping, and he's recently published a paper on the cost effectiveness of CYP2C19 studies in our local context as well. So while genotyping capabilities first hit the clinical practice, they were costly and very, very out of reach for patients without much funding. And also there are alternative agents that we know today. In Singapore, we use a lot of ticagrelor, I'm sure in most of the other countries as well. And I think in Japan, they use a lot more prasugrel. And so it puts the clinician much in a quandary, because then what happens if your poorer patients cannot afford the alternative agents? So in this talk, Mr. Kim will share how assumptions could influence cost effectiveness of a strategy for genotype-guided selection of drugs, with application to his work on CYP2C19 guided choice of P2Y12 inhibitors. He will also briefly cover the role of sensitivity analysis in the calculation of cost effectiveness. Let's welcome Mr. Kim.
Cost effectiveness of genotyping down the slippery slope. Hi everyone, I'm Ji Heon. I'm a senior clinical pharmacist from Khoo Teck Puat Hospital in Singapore, and I have no conflict of interest to disclose. Please note that I'm by no means a HTA expert, so this presentation is really pitched at an introductory level, and I'll be using my own paper as a case study. So before we decide to do a cost effectiveness analysis, we have to ask ourselves, what is the research question? Specifically, why do I want to conduct this cost effectiveness analysis? So in my case, my research question was, is CYP2C19 guided antiplatelet therapy for acute coronary syndromes cost effective in Singapore? So what are some other questions we have to ask ourselves? Are there studies out there? So based on my own literature search, I noted that there are several studies, but few were conducted in Asian populations that yielded conflicting results. Are the study findings generalizable to my population? Well, in my case, I felt that the study findings were not as generalizable due to the different prevalence of loss of function alleles and the different healthcare financing structures. So is there a difference in outcome? Yes, because if there's no difference in outcomes, you'd probably want to go for cost minimization analysis. Whereas if you anticipate that there's a difference in outcomes, cost effectiveness analyses or cost utility analyses may be options for you, depending on your outcome of interest. So in my case, because my outcome of interest was incremental cost effectiveness ratio, or ICER for short, in Singapore dollars per quality adjusted life years, this study can also be termed as a cost utility analysis. So moving on to methods, whose perspective, societal, healthcare system, or patient, and who. So before you decide on your cohort characteristics, you have to ask yourself, what is your patient demographic? And what is the demographic of patients in your references? So in my case, I chose a hypothetical cohort of patients aged 62 years old at ACS onset. This not only resembled patients that were enrolled in clinical trials, the median age of STEMI was also 62 years old in Singapore based on our own registry data. So what are the treatment strategies to consider? So in my case, 3 DPT strategies were considered. The first one being universal clopidogrel, followed by genotype guided, and lastly, universal ticagrelor. What cost? Direct and or indirect costs, local currency, what year to account for inflation, and if the data were obtained from a foreign currency, what is the exchange rate used? So in my case, I only accounted for direct costs in 2019 Singapore dollars. So what utility? Any local data? If not, are the findings transferable to your population? And is ICER your main outcome? So ICER can be defined as the additional cost for an additional unit of effectiveness. And this can be calculated as the change in cost over the change in effectiveness. So as you can see from the equation, which strategy are you going to serve as a control? And does the historical control reflect current practice? So for instance, we know that clopidogrel has historically been served as a control for your newer P2Y12 inhibitors like ticagrelor. However, now international guidelines recommend ticagrelor over clopidogrel. Do bear in mind that current practice is also country dependent, as the cost of ticagrelor may be prohibitive for universal adoption in many low to middle income countries. So what model structure should I use? Well, this will depend on whether there are repeat events. So if there are repeat events, you'd probably be better off with a state transition model like the Markov model. However, if there are no repeat events, you can just go ahead with the decision tree model. What is your time horizon? And do I need to account for discounting? So in our case, since our time horizon was just 1 year, there was no need for discounting. Moving on to references, for efficacy endpoints, I used a single study by Cavallari and colleagues to obtain the event probabilities for death, myocardial infarction, and stroke. This was because this was the only study, the only prospective study that reported events based on drug gene pairs. And while the prevalence of loss of function alleles in this study was 31.5%, we can account for local prevalence of 61.7% when we were calculating the event probabilities. Sadly, I could not use the findings from the Popular Genetics and the Taylor PCI, both good trials, because the prevalence of loss of function alleles was approximately 30% for both studies, yet the events were not reported in drug gene pairs. For safety endpoints, I used the Plato Genetics sub-study to obtain the probability for non-cabbage major bleeding. So coming to results, if I can draw your attention to the first diagram. So as you can see from the ICERS, we know that both genotype-guided and universal ticagrelor were cost-effective strategies compared to universal clopidogrel. And this is really based on the willingness to pay threshold of 88,901 Singapore dollars, defined as one time the GDP per capita in 2019. However, as you can see from the second diagram, universal ticagrelor was not cost-effective when genotype-guided strategy was taken as a reference. So this is the tornado diagram for universal ticagrelor versus genotype-guided strategy. So the beauty of the tornado diagram is that it can be used to present your findings from a one-way probabilistic sensitivity analysis. And what's so good about these diagrams is that you can show the relative importance of your variables based on how much they can influence your ICER. So as you can see, if I can just draw your attention to the cost of ticagrelor, we know that as the cost of ticagrelor approaches the lower limit, the ICER decreases and falls below the willingness to pay threshold, allowing universal ticagrelor to become more cost-effective than genotype-guided strategy. So from additional sensitivity analyses, we determined that once the cost of ticagrelor is less than 1,196 Singapore dollars per year, and that's about $1.64 Sing dollars per tablet, universal ticagrelor will be more cost-effective than genotype-guided. In that scenario, the test cost must be less than 88 Singapore dollars for genotype-guided strategy to remain cost-effective. So how do I apply the findings from this study? Well, firstly, we can consider universal genotype-guided strategy for all ACS patients. We can also consider subsidies for CYP2C19 testing, such that any decrease in cost of ticagrelor can be offset by a decrease in test costs, allowing genotype-guided strategy to remain cost-effective. Lastly, the clinical criteria may also be used to further refine drug decisions. This is because we found out from further analyses that as long as 55% of all patients genotype receive a P2 wild-type inhibitors based on their test results, genotype-guided will still remain cost-effective. So in summary, these are the 4 things I've covered. Number 1, how to conduct a cost-effectiveness analysis with why, who, what, how, and when. The results of my cost-effectiveness analysis that show that genotype-guided is the most cost-effective DPT strategy. Number 3, how a decrease in the cost of ticagrelor may cause universal ticagrelor to be more cost-effective than genotype-guided. And number 4, the application of the findings, such as the consideration for subsidies to decrease test costs, and how the clinical criteria may also be used to further refine drug decisions.
Many thanks, Mr. Kim, for sharing your work. And that was indeed a cost effectiveness 101 session for everyone to listen to. So I'd like to welcome our panelists today. And of course, Dr. Pereira is here personally with us. Dr. Pereira, hello. And we'd like to add on also to the panel, Professor Mark Chan, who is from the National University Hospital. He's a senior cardiologist and he's done a lot of work with antithrombotics. So we'd like to hear his points of view about the topics this morning. And of course, Mr. Kim himself, who's going to answer some of the cost effectiveness questions, I believe. So maybe let's just start off with talking with everyone now. I'm very interested to talk to Dr. Pereira and Professor Chan here. And we hear commonly a lot of cardiologists think that, oh, we do a lot of risk assessment clinically anyway. And it seems like CYP2C19 doesn't add too much more to the decision making. What are your thoughts about that question?
Well,
maybe Dr. Pereira first? Yeah.
Yeah, it's very interesting. If you look at Taylor PCI, we basically looked at patients, the total number of patients that were part of the primary analysis were 1,800 patients. And with 1,800 patients who were loss of function allele, we showed a 34% risk reduction. Now, I know the p-value was 0.056. It was borderline. We powered the trial for 50% reduction, and that's why we missed statistical significance. But if you look at the analysis from a Bayesian perspective, with the effect size, the hazard ratio being 0.66, the probability of Taylor PCI results not being true is less than 3%. P-values are probabilities. And so it's very important to understand that when you see a borderline p-value, always look at the effect size. If the effect size, for example, we know Entresto and heart failure with preserved ejection fraction, the p-value was also 0.06. But the effect size was small. The hazard ratio was 0.8 something. Here, this is very different. The effect size is fairly dramatic. And so the probability of our results not being true is very, very small. It took 1,800 patients to show this difference. And if you look at Plato, which was conducted now more than a decade ago, the effect size, the hazard ratio was 0.8486. So the risk reduction with Ticagrelor in the overall population, when you compare it to clopidogrel, overall in Plato, the risk reduction was about 16%. But if you take loss of function patients, the risk reduction was 34% in our Taylor PCI. If you look at a meta-analysis, the risk reduction is about 30%. If you look at the Plato genetic study, the risk reduction was 33%. So I don't think a risk reduction of 30% is a small risk reduction. And I think genotype has a significant effect in influencing the action of clopidogrel versus Ticagrelor versus clopidogrel. Now, the overall event rate with the newer generation stents is small. So if you look at Taylor PCI, the ischemic event rate, if you include recurrent acute coronary events, was about 5% or so. Plato was about 10 to 12%, but that was 10 years ago when they used older generation stents. With the newer generation stents, the ischemic event rate is quite small. If you just use myocardial infarction, stroke, stent thrombosis, and cardiovascular death, the event rate is even smaller. It's 2 to 3%. So I think people say most patients who undergo angioplasty or stenting do not have a problem, and that's true. I mean, more than 95% of patients, they get any antiplatelet drug. The chances of an event occurring in the first 12 months after PCI is less than 5% in the modern era of new stenting. But if you take that small event rate, there's a 30 plus% difference if you have loss of function allele versus non-carriers.
So, Dr. Pereira, it sounds like you are advocating genotyping for most people who fit the criteria of the clinical trials. I'm just thinking maybe Prof. Chan can pipe in his 30-second thoughts about this issue before I move on to warfarin and Mr. Kim's thoughts.
Yes, first, congratulations to Professor Pereira for conducting a very nice study tailored PCI. I think that given the points raised, adding a few hundred more patients would probably have resulted in a significant p-value for the study, and agree with the effect size being rather impressive. I think that we still have a somewhat conservative approach with the cardiology community in Singapore, and genotyping is still done in a very individualized fashion. I hope that maybe Professor Pereira may consider a second trial because I believe that the individualized approach here would be first based on patient clinical factors as well as procedural factors, and then the cardiologist decide whether an individual patient should deserve undergo genotyping. So maybe a second follow-up trial with larger numbers, including clinical factors, procedural factors, and genotype, may be what we need as tailored PCI too.
Spoken like a true trialist, Dr. Chan.
No, Dr. Chan, it's very difficult to conduct these trials, which are primarily biobank based, and there's a lot of bias that's involved, and people find it hard to enroll patients in such trials. I think when the overall event rate is low, you are absolutely right. I mean, using just it would be nice to identify those less than 5% patients who are going to have problems, while majority of patients are not going to have problems, even though they have CYP2C19 loss of function status. And so we actually have conducted an artificial intelligence-based analysis using multiple clinical variables to be able to identify, including genotype, to identify that high-risk group. And I think if you're able to identify the high-risk group and then demonstrate significance with a genotype-based approach, that would be useful. One of my colleagues, Dr. Dominic Angelillo, has published the ABCD gene score. And I don't want to usurp his findings, but what it does is it also combines clinical variables with genotype. And doing that, so Dr. Chan's absolutely right, will enhance the ability to predict the patients who would be at increased risk for ischemic events. And that would enable more precise delivery of CYP2C19 based P2Y12 inhibitor therapy.
Yes, absolutely. Thank you for sharing your pulse of wisdom. We've actually run out of time, and I don't have much time to deal with some of the other questions. But quickly, maybe Mr. Kim, can you deal with the question on the INR intervals as well as warfarin?
Okay. I think there was a question earlier about INR interval. I just want to say that it's difficult for me to comment on the exact duration for INR interval, but based on the studies, mainly from the CNET colleagues as well as the UPEC study, we know that that warfarin genotyping decreases the number of dose titrations as well as the time to therapeutic INR. So indirectly, if you want to bring it back to practice, this may translate to reductions in the number of INR tests as well as the follow-up appointments as well. And this may in turn translate to more patient savings. Yeah.
spoken like the true cost effectiveness guru there. So just to sum up for everyone, I think there were some questions about whether genotype tests are validated in Asians. I think the impact size is similar for both Asians and Caucasians. There's not much of a difference. There's a lot of clinical data out there that genotype guided therapies are going to be safe and somewhat effective if you're using them for the right populations. So it leaves me just to thank the panel today. Thank you for your pulse of wisdom, and I wish you a good Sunday ahead. Please join us for the next session, which happens in 5 minutes. Thank you.